Good morning, everyone. I'm Farooq Aziz, one of the consultant spinal neurosurgeon working at Middlesbrough James Cook University Hospital. I'm going to present Cauda Equina syndrome. Moving forward from there, I'm going to talk about the role of surgical intervention to reduce the permanent disability arising from the Cauda Equina syndrome. So I'm going to cover briefly, this is a slide which shows all the content I'm going to cover during my presentations, starting from introduction of the Cauda Equina. I'll try to be very simple in my presentation so that everyone can understand. I know there's a number of the audience, there's a difference. They are specialists and they are primary care is available, the primary care audience, and then patients as well. So I'm going to go through the etiology, pathogenesis, signs and symptoms, including red flag signs, how to classify the Cauda Equina syndrome, what's the best way to diagnose, and what are the surgical issues around the management of the spinal Cauda Equina syndrome, a very important medical legal aspect, and at the end I'm going to run a couple of case scenarios. So with Cauda Equina is a Latin word which means horse tail, and it was first described by a French anatomist, Lazarus, in 1600. So the Cauda Equina is actually the continuation of the spinal cord. The spinal cord ends at T12L1 level, from where it runs down the spinal nerves in a thecal sac, and that constitutes the Cauda Equina. And the function it provides is motor, sensory, and sphincter and parasympathetic innervation to the bladder and the distal bowel. Now, coming to the term Cauda Equina syndrome, this was first described in 1934 by Mixter and Barr, and it's a rare but disabling condition if it's left untreated. So the picture on the bottom of this screen, you can see there are three cross sections through the lumbar spine. And in the middle there is a triangular space which is a spinal canal which houses the Cauda Equina. The first picture on the left is a normal cross section where you can see the Cauda Equina is free. On the right hand picture you can see that there is a disc prolapse which is compressing the Cauda Equina, but still you can see there's a space around the nerves. However, the bottom picture shows that there's an acute prolapse and herniation of the disc, causing severe compression of the nerve roots in the thecal sac, and that is essentially the Cauda Equina syndrome picture on the MRI scan. Now the incidence, it's a rare condition, but it's disproportionately has high medical legal profile. The incidence is 1 in 33,000 to 100,000 population. It's about 2 to 6% of the lumbar disc operation is actually Cauda Equina syndrome. One has to have a high clinical suspicion in patients who are presenting with lower back pain and sphincter problems. And the key is good history and physical examination to diagnose this condition. Now, in terms of the pathologies which can cause Cauda Equina syndrome, the most common is the herniated disc, which prolapses acutely and causes the compression of the Cauda Equina. The other less common conditions or pathologies which can cause Cauda Equina syndrome are tumor, trauma, hematoma, abscess, and there are other less common conditions which can cause similar presentation. Now, the pathogenesis of Cauda Equina syndrome is not very clear. Now, the most common explanation for this is when there's large central or paracentral disc prolapses, it causes compression on the nerves, and the nerves they get hyperperfusion injury, and in turn they get ischemia and they get damaged. So this is the most common explanation. However, there are some hypotheses that there is also a chemical mediated reaction to the nerves, or it could be a combination of both, the extrinsic pressure and the chemical reaction. Now, this is very important. The red flag signs, they are the key in terms of diagnosis, the Cauda Equina syndrome. The NICE, National Institute of Clinical Excellence, they have revised the red flag signs in December 2020. Essentially, they remains the same, if the motor motor nerves are involved, and it causes the neurological deficit in weakness, and if the sensory nerves When they are affected, then they cause paresthesias, numbness, and then the autonomic dysfunction, which can result into bladder and sphincter problems. And obviously the bilateral leg pain is due to the compression on the nerves. Now, the only thing which has changed more recently, that previously these red flag signs are all based on objective assessment. When the patient comes in and patient's been examined and the documented clinical signs have been written, then it's an objective assessment. So at that previously it was not considered as a red flag sign if the patient is complaining they have numbness, which means subjective feeling of numbness, and if the patient is examined and they have got a normal sensation, they should be considered as normal. But now the subjective assessment is also important. If the patient is complaining of numbness, so that's still be considered as a red flag sign. So that has changed. In terms of the sign, the most common consistent sign in Cauda Equina syndrome is urinary retention, and the incidence approaches to 90%. So that's of paramount importance to examine these patients pre and post void residual volume in the bladder. So the normal after passing urine was 50 to 100. If it's more than 200, so that's significant. It means the patient has developed a Cauda Equina syndrome, and then the further they need to be investigated with an MRI scan, because the diagnosis is not only clinical, there's also a radiological element. The next commonest sign is the loss of anal tone. Now, in terms of the sensory presentation, about 75% of the patients presented with Cauda Equina syndrome have saddle anesthesia. In the picture on the right, you can see that this is the perianal sensory examination is very important in these patients. So from S2 to S4, if there is a perianal sensory loss, either objective or subjective, either it's been picked on the examination or been described by the patient, is been considered as a red flag sign. Now, there are different variation in the presentation of the Cauda Equina syndrome. So the one presentation can be a rapid onset without the previous background history of pain, or and in that case an acute disc bulges out and causes compression with immediate involvement of the sphincters, and do they have pain. So that's one presentation. The other can be on the background of previous low back pain and sciatica, and the patient present with the sphincter problem, so that's another presentation. So it can be variable, and sometimes it can be over a period of time, especially in patients with a degenerative cervical lumbar spine, where they present with acute onset of sphincter involvement with the background history of back and leg pain. So this is the most important slide, that how to diagnose a Cauda Equina syndrome. So the diagnosis is not only clinical, it has to be a radiological diagnosis. So the investigation of choice is MRI scan, as there is no clinical diagnosis of Cauda Equina because it lacks sensitivity and specificity, with no single symptom or sign adequately predicting management or the outcome. So clinical presentation, examination, and the finding of a large disc compressing the Cauda Equina on the MRI scan, that makes the full diagnosis of the Cauda Equina syndrome. Now, this is another important slide where how to classify the Cauda Equina syndrome, because this is the most recent guidelines from British Association of Spinal Surgeons, and it's been very important to understand there are three different classes, or you can say three different stages of the Cauda Equina. It's very important to diagnose each of them and separately, so that as the treatment is different for all three stages. So the first one is where Cauda Equina suspected, where the patient presents with back or leg pain without any sphincter involvement. So high index of suspicion should be always always be considered. The second stage is when there's involvement of the sphincter. So this is classed as Cauda Equina syndrome incomplete. Now, this is when the patient started having problems with their bladder, dysuria, urgency, or altered urinary sensation. And then if it progressed further, then the third stage would be Cauda Equina syndrome retention. Some of the patients present straight with retention, so it's important to identify which stage of the Cauda Equina they are in. So in the retention one, the patient presents with painless urinary retention, or they have fecal incontinence or urinary incontinence. Now, talking about the surgical issues, the major point of contention with Cauda Equina syndrome lies with it all revolves around the timing, when to operate, when is the right time to operate. So I'm going to talk about the literature here. There are a number of studies being done to look at what's the best time to deal with this problem. Now, this is the meta-analysis from Johns Hopkins in 2000, where they looked at 322 patients from 42 publications. And what they have concluded that patients who've been operated within 48 hours, they are the one who gets the most benefit. And they look at another subset where they try to differentiate whether if there's any benefit of these patients operating within 24 hours. They found there's no significant difference as long as the patient has been operated within 48 hours. Then in 2004, this is from Portland group, which actually criticized the work of the Johns Hopkins, and they said that they have flawed methodology, and they said there is definitely advantage in patients treating within 24 hours over 48 hours. Moving forward, then there's a meta-analysis that was published in 2005 from Todd, who demonstrated there is a advantage in patients who've been operated in within 24 hours with the outcome of their bladder function, and it's been statistically important with the p-value of 0.03. Irrespective whether it's if it's 24 hours or 48 hours, so there's no doubt surgery is the best treatment option for Cauda Equina syndrome. And the question now is when to operate. I think that's where this classification system really helps. So the patient who presented with Cauda Equina suspected, then their treatment is different from the patient who presented with incomplete or with retention. The patient who presented with incomplete presentation, where they have got sphincter dysfunction along with the pain, then they should be operated immediately, either it's day or night, because they are the one they can progress into the Cauda Equina syndrome in retention, which means the changes can be irreversible. So surgery as soon as possible, but not at the expense of patient safety. So it's very important. Some patients have medical issues, so we have to weigh the risks and the benefit, and should be an open discussion with the patient. And it's very important when the surgery is being delayed, it should be documented in the notes, the reason and the actual basis. So regardless of etiology, presentation, once a diagnosis of the Cauda Equina syndrome is established, the recommendation is to treat it emergently, despite though there is no clear consensus whether to be operated within 24 hours or 48 hours. So based on this classification, I'm going to run through the treatment algorithm. So if the patient presented with suspected Cauda Equina syndrome, they should be offered an MRI scan, which is the investigation of choice. And if they have a positive scan, and the two outcomes, either it's a negative scan or a positive scan. If there's a negative scan, there's no disc bulge, then they should be offered pain relief and a follow-up. But in case if they develop sphincter problem, then the rest of their spine should be scanned as well to rule out any pathology higher up in the spine. Whereas patients with MRI positive findings, they should be offered surgery on the next day list or the elective list until unless if they develop retention and if they progress and develop retention. And if the patient opt not for surgery, then they should be made aware of the red flag signs, and they should be talked about, and should be safety netted, that in case if they develop any sign, they should report to emergency or primary care immediately. So this is the treatment algorithm. The patient with incomplete who present with pain is mainly symptom with so in incomplete they develop the sphincter disturbance, then it's an emergency that needs to be dealt there and then as soon as possible if the patient is safe to proceed. If the patient is in retention, which is a stage 3 of the Cauda Equina syndrome, then the treatment depends on the two factors. One, if it's an early patient presentation with retention, they should be operated there and then straight away. However, if the patient presented with retention late, then they can be done in the next available morning or elective list. Now, what is the goal of the operation? The goal of the operation is to release the pressure from the from the cauda equina, from the spinal nerves, by taking the disc out. And rarely the instrumentation is needed. It's mainly if there's a trauma, there's an instability in the spine, or if there is a degenerative disease and there's a risk that if you decompress, then it can cause the slip to increase. So it's mainly simple decompression. Now I've actually divided the surgical options into three. One is microdiscectomy, which is a minimally invasive procedure. A small cut is made and a small corridor is created and take the disc out. Now, it's not really a sort of a surgical intervention of choice, because the risk with this is that by taking the disc out, one has to do a lot of retraction to take the disc out. So it has to be an open and wide decompression, and then it's safer to do so. So that's where the laminectomy is most common procedure which is done for this problem, and as I said, that fusion is rarely needed. So this is the diagram. I put it for those who have not have a chance to go to theater or to see what we do in theater for this condition. So the picture on the left, you can see there is a disc bulge at L4 and L5 which is causing the cauda equina compression. So the procedure is done under general anesthesia, patient being put on the tummy on a special frame or a mattress, and in the theater we normally do the X-ray to mark the level of the compression. So once the level is marked, then a midline incision is made, which you can see in figure A. So after making a midline incision, the muscles and skin is retracted, and then you can see in figure number C that after the dura is exposed, after the theca is exposed, which houses the spinal nerves and cauda equina, then the disc is actually sitting in the front of the nerve, so that this thecal sac is retracted and the disc is being delivered either in piecemeal or usually with acute disc bulge it comes in one big lump. So this is how it's been done. So what are the outcomes after the decompression? So the studies have shown that if the surgery is done timely, as soon as is possible and it's safe to do so, that the patient do recover if it's done within 24 to 48 hours. So residual bladder deficit may persist despite successful decompression. So that's very important to document in the notes before, and a discussion should be, an open discussion should be with the patient to explain that it might not recover. The motor can take even longer to recover. So the post-op consideration is how these patients should be managed after they've been dealt surgically. So it has the ideal situation, it should be dealt under the umbrella of spinal injuries unit with a multidisciplinary and holistic approach with the involvement of the other specialties like urologist, gynecologist, and gastroenterologist. Now, another important aspect of this problem is the medico-legal implications. Now, why it's important? Because it's a rare condition and its variability means different presentation, and the patient can present late, and if being left untreated, so they can have a significant impact on their life. And the other problem with this is that the junior staff, they're not aware of this problem or the severity or the actual nature of this beast, because this is something which can affect the people as a whole, as a family, not only the person but the whole family. So I think that's where it's very important. The damages are most likely if the medical records are deficient with the lack of crucial clinical detail, including recording. So it's very important to document every examination, clinical findings, and scan findings. So Medical Protection Society, they have released the data over 5 years. They have received 105 claims, and most of these claims are against the GPs and the primary care. So I think that's where there's a role to improve the service and to prevent this happening in the community. So, and the figures they have released that most of these cases have been settled for 6 figures, and those where the negligence is established, then they run into millions. This is the data from MDU. They have received 150 claims over 11 years. So again, the majority chunk is from the primary care. More than 90%, they spend 8 million in compensation, and they have paid 4.5 million to the solicitors. This is the data from NHS Litigation Authority from January 2008 to December 2018. So what they have received is about over 800 claims, and 1/3 of the claims we settle with damages, and less than 1/3 being remain open. So what is Cauda Equina syndrome? So it's a bigger issue, and has a devastating effect on the quality of the life of patient if being left untreated. It puts a significant burden on medical service and considerable medico-legal implication, as I went through. So early consideration, diagnosis, and intervention are the foremost improving meaningful outcome for patients and reducing the large medico-legal burden on the NHS. So I'll quickly go through a couple of case scenarios. So this is one where a 34-year-old patient presented with back pain after moving some heavy stuff at the work, and then the initial diagnosis was made of acute disc bulge, and he was offered analgesia and was asked to go home, but he refused to go home because of his pain. On day 2, the patient notes that he developed some numbness. So from CES, which is a suspected in the first place, he moved to the next stage, which is incomplete, and a full examination was performed. X-ray was done, which was normal. MRI ordered, but that broke down, unfortunately. The CT scan is not the investigation of choice, so it was inconclusive unless if it's a CT myelogram, which gives more information, especially important in patients where the MRI is contraindicated. So patient developed urinary retention on day 3, which is 900 cc in his bladder, and he was transferred urgently for an MRI scan to a tertiary care, and this was his scan, you can see. So what's the outcome? So the urgent decompression was done, but it was delayed, so it resulted into permanent disability, which he developed incontinence. He had to quit the job and under psych care. The second case scenario, where a 36-year-old male presented with retention, but within 24 hours he had a 500 residual urine. Immediate MRI showed a large disc bulge, which was dealt within 24 hours, and luckily he recovered. So I think that's where the importance is, that this should be dealt earlier and should be investigated. And once it's diagnosed, the treatment of choice is surgical decompression. To summarize, so 1 to 2% of the acute disc give Cauda Equina symptoms. Always have a high index of suspicion. Examine the patient, perianal sensation and anal sphincter tone. If suspicious, then get the MRI scan. Treatment should be based on the classification I've discussed, and immediate treatment may avoid severe disability. Thank you.